We will review next the Medical Device Accessories Guidance. This is a very noteworthy document in terms of implications in the mobile health industry. The guidance was published in its final form in December of 2016. The FDA has traditionally determined the classification of device accessory types in one of two ways. First, by inclusion in the same classification as the parent device, and second, and only when the first way is deemed not appropriate, by issuance of a unique, separate classification regulation for the accessory. We're seeing, however, a proliferation of the utilization of mobile health apps, software, or other types of devices as accessory to traditional medical devices with a functionality that is traditionally regulated by the FDA. And the FDA has acknowledged this trend and decided in December 2016 an amendment of the medical device definition. It was, in fact, the act that was amended by the 21st Century Cures Act, which we will mention again later, stated that we will review the risk intrinsic with the accessory as is used with the parent device, separately from the risks that are associated with the parent device, opening the door potentially to a classification of the accessory that is different and lower in risk than the classification of the parent device. To restate, the risk of an accessory, since very recently, December of 2016, are the risks that the accessory presents when used with the corresponding parent device as intended, and are not inheriting the risk of the parent device necessarily. As mentioned, this has important implication in mobile health, in that it is an important departure from what was previously done in this space, and it opens a possibility for many apps, sensor, or devices as being regulated as an accessory of a medical device with a different risk classification profile and therefore a different risk categorization. Now, I'd like to spend the remaining time of this module presenting on a number of mobile health devices. And since we have talked about apps, these examples are meant to illustrate the breadth of devices that represent this industry beyond just mobile apps. I'd like to start with an app, however, and particularly with an example that's perhaps by now of, again, historical significance, considering how much the state of mobile health has changed since 2011. The mobile MIM software program, as shown in this slide, is used for the registration, fusion, and/or display for diagnosis of medical images from various modalities. It provides wireless and portable access to medical images. This is one of the very first clearances from the Food and Drug Administration, and it was one of a very interesting and rather long path. FDA originally told the manufacturers that the PMA was to be required, and as you may know, a PMA is required only of devices that are highest in risk, and is a rather expensive and laborious process for the manufacturers to see through the end. It went to an appeal, and later an FDA 510(k) clearance was achieved in February of 2011 with some amendments over the original intended use claim. Specifically, the FDA asked that these amendments be added to the intended use. This device is not intended to replace full workstation and should be used only when there is no access to a workstation. This device is further not to be used for mammography. This amendment reflects, if you will, some initial skepticism on the part of the FDA on the ability of this technology to perform just as well as technology supporting this traditionally regulated medical device functionality. I would say that this has been dissipated. This is a claim that is often found in 510(k) clearances of devices in the mobile health area. And it is also wise to think about risk mitigation strategies when approaching the FDA to give comfort that situations in which, for example, poor lighting or the limited capabilities or just about the mobile nature of this technology is not preventing them from achieving their intended use successfully. We've made example of the Proteus digital health technology previously, and this has been an interesting device to watch also from a regulatory perspective. As you may remember, simply said, this technology consists in a chipset embedded in a pill that once digested triggers a signal sent to a Band-Aid-like sensor, and the signal is then translated and wired to an app or other piece of software that lives on a tablet, for example, and provides some insight into the medication taking behavior of the person that is taking the pill. This was a very cleverly done piece of regulatory story for Proteus Digital Health. A first clearance was achieved in March of 2010 for just the wireless patch, with a number of predicates used to support equivalency of the intended use. The technology that embeds the chipset on two pills finally achieved de novo clearance roughly about 2 years later in July of 2012, and since then subsequent clearances have been achieved in 2013, 14, and 15. This is an example of how the agency is oftentimes working with pioneering technology companies in this area to appreciate how it can work with them to continue foster new innovative technologies while at the same time ensuring that they are safe and effective for public health. We review now the wireless ear lens light-driven hearing aid. The ear lens contact hearing device, or CHD, is manufactured by Earlens Corporation that is also very close to us in Menlo Park, California. The wireless Earlens CHD is a hearing aid that transmits amplified sound by vibrating the eardrum through direct contact. It is indicated for individuals 18 years and older with a mild to severe hearing impairment who can benefit from amplification. It may sound pretty similar to existing technologies. However, this device differs from traditional air conduction hearing aids in that, for example, uses small speakers and uses lights to transmit sound, comes equipped with a fitting software and a wireless charger. Up till now, this technology might seem pretty similar to previously existing technologies and other hearing aids, but it does differ from traditional air conduction hearing aids in several ways. Unlike traditional hearing aids that use small speakers, this technology uses light to transmit sound, comes equipped with a fitting software and a wireless charger. This mobile health technology is a Class 2 product per FDA regulations, and lacking an obvious predicate device for substantial equivalence determination through a normal 510(k) process, it obtained instead the de novo clearance to market in 2015. Next, let's review the infant feeding solution by Infant Labs. This device is comprised of a portable multi-use electronics unit, a single-use bottle, coupling, and a mobile application which acts as a user interface and data display. It is intended to measure movement of the nipple during non-nutritive and nutritive sac. And the nipple movement data is transmitted to a mobile device and displayed for clinician interpretation. The intent here is to provide objective data to help clinicians guide premature infant to a safe transition to independent oral feeding. I chose this example also because it's an example of mobile health technology that actually lives within the hospital environment. It is not intended to be used in the home environment. This Class 2 device received 510(k) clearance in 2015. Now, this one is really worth mentioning and is quite recent at the time of this recording. The world's first FDA-approved hybrid closed-loop system is shown in this image, the Medtronic MiniMed 670G. This device constantly self-adjusts to keep the wearer's sugar level in range. It includes a glucose sensor that offers 7-day continuous wear, as well as a transmitter that powers the sensor, collects and calculates sensor data, and wirelessly sends the data to the insulin pump. As you can see, mobile health really is not just about enjoyable little apps, but very complex technologies belong to this industry that the FDA obviously intends to continue regulate, in that their intended functionality is very much within the domain of the agency. This is intended obviously for the management of type 1 diabetes mellitus in persons 14 years of age or older. And this high-risk, life-sustaining device was approved via a pre-market approval application pathway in 2016. As an additional example, I'd like to present the InPad, the smart insulin delivery system that combines feature of insulin pens and insulin pumps into one system. Explained simply, it is an insulin pen that also connects to smartphones to help track intake, calculate dosage, and manage how much is in reserve. It is not a closed-loop system in that the dosage still has to be dialed in from the old-fashioned manual way once the app displays a recommendation. And it's obviously very much a reflection on the fact that an essential piece of hardware is a component of the system that we cannot just rely upon as we could from the previous system by Medtronic, the smartphone. Consider just the case, for example, of the smartphone running out of battery. That is one very good use why a risk mitigation strategy is in place for this loop not to be closed by the manual intervention of the user. This companion medical received FDA clearance on the InPen smart delivery system also in 2016. This is instead a Switzerland-based company that has created Triggerfish, a nice, clever device that probably is suggestive of a similar-looking innovation now at Google. The device received a de novo FDA clearance also in 2016 for this connected contact lens, which helps physicians track the progression of glaucoma in patients. The sensor-embedded contact lens records continuous ocular dimensional changes for 24 hours, and the data is then sent from the lens wirelessly to a recorder that users wear around their neck. After the recording period has ended, the data is transformed from the recorder to a physician's computer via Bluetooth, meaning that the patient needs to return to the physician office to upload it. It very much beats existing solutions that instead require very complex evaluations and not particularly accurate one at the physician's office. If it all sounds very easy, well, it really isn't. Not all mobile health devices have the same level of sophistications as the ones that we have just reviewed. And as mentioned before, your Google Play Store or Apple App Store are full of other mobile health apps of dubious safety and efficacy. And these are just some examples that I think are interesting and borderline funny. The acne app, for example, utilizes iPhone light to cure acne, until the FTC intervened in 2011 to remove it because, well, it simply hadn't demonstrated its ability to do that. The cardiac stress test app allows you to do 30 squats and take a pulse to see if you can play sports. The eyesight lamp uses iPhone light to cure seasonal affective disorder, and many other examples such as this one. Interestingly enough, the FTC and not the FDA, in its capacity to regulate false and deceptive advertising, has already brought enforcement proceedings against the developers of a number of private health apps, such as the ones listed here. And the one that was claimed to treat acne, for example, was removed, was just the first one of a series of apps that had similar claims. They were removed from market in order to protect public health, something that we traditionally associate with the FDA. It's not surprising in that the FDA and the FTC have traditionally collaborated to fulfill what is essentially a very similar mission, only the FDA does so with a public health emphasis. But we will see more examples of this type of synergy between the two agencies in the next module. Whereas the FTC removal of the acne app didn't quite make the news, other cases when the FTC intervened have, such as the case of Lumosity's brain training program. Early in 2016, the creators of the program agreed to settle FTC charges, alleging that they deceived consumers with unfounded claims. We'll talk more about these and other examples of FTC's intervention in mobile health in the next module. In addition to that, we will look beyond mobile health regulatory trends to better understand health IT, IMDRF, and software as a medical device, also known as SMAD. We will try to better understand clinical decision support software in that it does overlap significantly with the development of mobile health app and related technologies. We will review 2017's regulatory science priority from CDRH that are relevant in order to appreciate some of the changes that we might see coming from a regulatory perspective that have implications in mobile health. And we will conclude the next module with plenty of examples of software with medical health management functionality.